Would you like to
Right. Hello, everyone. Thank you so much for being here today to attend the Stanford Prostate Cancer Symposium. This is our second year following a very successful first year with Dr. Amina Huda at the helm. And I am grateful to be back to be able to moderate this session. Thank you, Lori and Mary Kay Asuncion and Linda Plout for getting this event off the ground. As you know, my name is Sharon Chin. I'm a physician assistant. I work in the Department of Radiation Oncology. And I'm here to moderate the next session, which is the patient perspective. We generally have three patients that are here. Unfortunately, our third had an unforeseen circumstance and isn't able to be here today. So today we have two courageous speakers who are going to share their prostate cancer journey. Each of them have chosen a different route for treatment, and they will selflessly and candidly speak to their experience. Following each speaker, we'll go ahead and take questions, so please feel free to jot down your questions so that they can address it. As much as this was their journey, this is also your journey as well. All right, so our first speaker today is Mr. Thomas Lee Steckmest. But please don't call him Tom as in Tom Cruise, because in his circle of friends, he is known as Lee. Lee graduated from Duke University with a degree in electrical engineering when massive mainframe computers were still new. He, like Tom Cruise, was a hotshot, handsome U.S. naval officer. Following his military service, he worked at IBM for 35 years using his Tom Cruise good looks in the Department of Sales and Marketing. Sorry, ladies, don't get too excited. He's already taken and has been married to his beautiful wife for 54 years. I know, all the good ones are always taken. Following his stint at IBM, he maintained his Tom Cruise physique and climbed mountains and hiked all over the world. He is also an active volunteer for his local Community Emergency Response Team program, also known as CERT. CERT trains volunteers in basic disaster response skills such as fire safety, search and rescue, team organization, and disaster medical operations. And after a busy day of saving the world, Lee likes to go home, kick up his feet, and enjoy a better-than-average single malt scotch. So Lee was diagnosed with low-risk prostate cancer in 2018, and he has opted for active surveillance. I know that Lori had already spoken about it, but here's a little recap. Active surveillance is an option where cancer treatment is not immediately provided and basically involves regular interval follow-up visits to monitor the potential progression of the disease through physical exam, blood tests, imaging studies like rectal ultrasounds, MRI scans, and/or prostate needle biopsies. Please welcome Mr. Lee Steckmest.
Thank you very much. I'm not sure all of that was accurate, but it was a nice introduction, and I appreciate it very much. It's a pleasure to be here. My talk's going to be not as serious as some of the ones you had before, because I'm not of a serious nature, but I was surprised to see this meeting was convened by Dr. Subek from the Department of Gynecology, so I assume they're trying to expand their field of what they can practice by getting into prostate work here. So what is active surveillance? You've heard Lori Gelman speak earlier about what is constituted in an active surveillance. And basically, it's you and your care team keeping an eye on what's going on. It's something you don't realize is an option. In my case, my doctor, when I turned 60, said, "Why don't we get a PSA test?" And the PSA came back as, just over 4. So it was not a big deal, and for the next many years, we had regular PSA tests until it started creeping up, and then it became necessary to do other things. But at the time, and I've heard now that the testing has dropped down into the 40s, but at the time, 60 was about the normal start point to have some sort of exams. Guys don't pay a lot of attention to prostate cancer because it's not something we think about. I mean, skin cancer will get you before prostate cancer will. Lung cancer will get you before prostate cancer will. Those are the ones you hear about. So when prostate cancer raises its ugly head, you sort of have to stop and go, well, I don't know much. So sessions like this are invaluable. I've learned some things today that I didn't know before. And if I could do anything, I would encourage Sharon and Lori and the team to have some sort of introduction for people who have been diagnosed so they have a better idea of some of the parameters. Because there's a lot to this. Because, you get a PSA test, it's a blood test, it comes back with a number, and, it's either a yawn or it's a whatever, and if it starts creeping up, then you get other tests that's going on. But it's important to understand that, and then Lori gave you all the numbers, so I'm not going to go through them again about what's, what are the level of incidence. But if I could summarize what happens when you learn about prostate cancer, in my life, it turned into two things. And the military used it when they went into Iraq, shock and awe. The shock of understanding that you have cancer, and the awe of when you have to understand what you need to know to help make good judgments in your treatment. So the shock is always the disbelief. Why me? Why not the next guy? Why did I get it? I don't mean to pickle you, Tom. You see PSA numbers. They're an interesting number. They go up and down a little bit over time. I'll tell you, one of the greatest assets of the My Health system we all have access to as Stanford patients, is that you can get graphs drawn very quickly of results. You don't have to wait for your doctor to do it. You can get graphs drawn, you can see what's going on, you can start seeing the PSA line move, and you can start looking at the slope of the line, and the mathematician in the back, so it's the stuff we used to do in engineering school. We worry about slopes of lines and things like that. So you get some. So when you have discussions with your urologist, just because it's gone to 7.1 doesn't mean it's the end of the world, because if it's on a slope that's been that way or it's been level for many years, you look at it differently. By the way, most guys don't even know what a urologist is. I mean, we don't interact with urologists normally. I didn't talk to a urologist until I was in my late 60s, because most of the problems, if I had any, were handled by my primary care physician. A little sidebar: when I was in the Navy during the Vietnam conflict, I was on a ship. I was a communications officer. We had just less than 1,000 people on board, 300 in the Navy and 700 Marines. We were an amphibious transport ship. Our job was to bring the Marines anywhere in the world they were needed to, take care of problems. We had a doctor on board and a dentist. Now, first of all, can you imagine doing dental work on a ship that's pitching and rolling and rocking and moving back and forth? He was only popular during calm seas, I can promise you that. So he spent a lot of time helping the doctor, which on a ship like this spent most of his time doing sutures, fixing, broken bones, things like that. Because when you have a ship of basically an average age of 20 years old, people make a lot of problems and they have things. But he was also a trained urologist. And he was bored aboard a ship doing things he wasn't trained for. So he would occasionally have some fun. And when I learned about urologists later on, I had a bad impression because this guy had a sense of humor. One of the things when we would hit the beach or go on Liberty, we would have sometimes 400 or 500 guys hitting the beach, and they'd come back with all sorts of urological issues. Most were solved with massive doses of penicillin. But occasionally he would give the young guys, he'd say, here, take this pill tonight before you go to bed, and if you notice there's any change in your urine, please come back and see me. Well, there was a bright orange change to their urine. So if you have any doubt what the pill is, ask one of the doctors in the room or the nurses, and they'll be glad to tell you exactly what the pill did. The point is, he had fun, while at the same time, when the people would come back, he'd educate them and say, hey, you got to be careful what you do on the beach, because sometimes it could have lifelong implications, especially when it comes to your gynecological approach. So getting back to my story, the shock was very definite, the definition of what was going on. And it took me a while to realize the urologist that I work with is a very serious guy. So, you know, there was a calibration on my part to get back to where I had to be to have that definition. So I was told, look, let's do the non-invasive MRI and see what's going on. And they did that, and the results came back, and it became one of active surveillance now because there was something on the MRI that didn't look right. So we moved from active surveillance to what you might want to call expective management. We're expecting something, so let's figure out what it is so we can do it. So we started doing periodic tests, and we shared in the decision Sharon making. Now, I will give credit to the Stanford folks of how they will get multiple people involved to help you make your decision. I really give Stanford credit for that, because you're not just talking to one person. You know, this is not a small town in Iowa where there's one general doctor who does everything. I mean, the breadth that Stanford has is incredible. The breadth that UCSF has is incredible, and we're lucky to have this level of resource available to us. In my case, I had you know, I had a low Gleason score after the first test, so I was put in what you call active surveillance at that point. So let's talk about my adventure. It started back in 2005. But by the way, I'm 78, so I'm at the, you know, I'm older edge here. So from 2005 to 2017, we'd do periodic PSA tests, and it was slightly elevated, but it didn't do much. It just sort of, you know, bounced along in this. In 2018, it tilted up, and that's when we had the MRI and the truss procedure. Now, I love hearing women talk about the truss procedure. It's a guy procedure. It's not a lot of fun. This is where they, as Lori explained, there are two different approaches to getting to the prostate to take samples. There's this thing called an Artemis machine that is used. If I can encourage anything here, doctors, PAs, nurses who use that machine, please don't call the probe a gun, which is technically what it's called. You know, you're there, you're in a very compromising position, someone's working in a part of your anatomy you don't want them to work in, and someone says, let's get the gun ready, you know. Let me tell you, I tighten up. There's no question about it, which is just the opposite way they want you to go. At the same time, you know, they use a certain size needle to take the biopsy. And the people who joke, they say, oh, well, this is a big guy, let's get out the 8-gauge needle instead of the 16. No, come on, let's keep it straight, because you know, I'm nervous in that position. So in 2018, I had this procedure, small, low-grade cancer, fine, Gleason score of 6, and away we went. So we started talking about what was going on, and at that point, I started learning what was going on, because I didn't understand prostate cancer until someone came back and said, bingo. There's almost too much information available. It'd be nice to have prostate cancer for dummies, just a starting point so you can start understanding some of the things that the doctors have talked about this morning. By the way, those presentations were fabulous, and I'm glad you're down in the South Bay, because I live down there too. So I started taking an active result. I started developing an Excel spreadsheet of all my results for all these years until I realized my health did it. The MRI, the PSA started going up a little bit. So so last year, I mean in 2021, I had a MRI. Basically, it came back, no new findings, no need to do anything else, which, by the way, is what I like to hear. By the way, I have fun getting in the MRI tubes. Let me tell you, I have to go to Redwood City. They have some special ones there that help me get through the whole thing, because there is some concern when you get in there. There's no question about it. So in 2022, my PSA started going up a little bit more. So it became a little more aggressive active surveillance, is the right way of saying it. In 2023, I had another MRI. The radiologist said there's some suspicious lesions now that we're not sure what to do with it. So they said, there's also something over here in a node, we're not sure what's going on either. So I went and did a PET scan. PET scan came back and said, nope, everything's cool there, don't worry about it. And then, however, the PSA kept creeping up. Now, ladies and gentlemen, if you want to have fun with your urologist, have active sex and then get a PSA test 2 hours later. You will get a spike that will drive them crazy. I mean, I went from a 7 or 8 to a 19. And my urologist just about fell out of his chair. Well, I did it a month later and it dropped right back down where it should be. So if you want to have fun with your urologist, I will tell you that's a very good way to do it. I had another truss procedure on Monday of this week. And I've been, dancing around until they got the results back. Got them back yesterday, and it's still a 6. So things haven't really progressed, even though there was evidence in the MRI. This is the life I'm in now with active surveillance. It's doing things, repeating things, measuring things, being patient, but most important, it's learning as a patient what's going on. Now, here's my opportunity to complain to all the professionals here in this room. You have the worst measurement systems in the world. You have too many measurement systems. Why don't we get down to something simple? I mean, I'm an engineer. If we build a building like this, we use a very simple measurement system. There's not a lot of things like, well, what stage are we in, and what's the TMN staging going on here, and what's the Gleason score, and why is some scores like a 3-4, okay, but a 4-3 is, to the average person on the outside looking in, it don't make sense. And it makes it hard for us to understand as patients what can be done. So I don't know if there's a solution, and I heard all these things this morning, but it is very hard to get your head wrapped, as a patient now, to get your head wrapped around this world. So if I can do anything to help those of us who have prostate cancer, is help clarify, make it easy for us to understand. Because any score where you have 0 through 5 added to 0 through 5 to give you a number that then it can be repeated in different formats to mean different things. If we did that, we'd never put a man on the moon. Never. I also, there are some things that I heard mentioned today, like the National Comprehensive Cancer Network. It's interesting. As a patient, I don't have access to that for that information. Yeah, you have to have a sign on and be a doctor and all that sort of stuff. So again, it'd be nice if we had access to as much information as possible, because typically those of us who are professionals need data. I don't need less data, I need more data. I might get the wrong data, but at least I'm becoming more informed about what's going on. So what are the tips? You are your own advocate. You got to be that. You got to be your own advocate. And you have to educate yourself. And more importantly, don't believe what you see on the internet. I mean, there's so much nonsense out there, it makes your head spin. And when you go talk to your urologist or your radiologist or your oncologist or whatever ish you're talking to, take someone with you if you can. Because you're not going to hear everything they say, and you're not going to understand everything they say. And the nice thing about Stanford is we can interact back and forth over my health, and it's been invaluable to helping my understanding of where I am and what I have to do. Don't be shy. Ask a lot of questions. It's only your health. And you will never hear a Stanford doctor say that's a bad question. I mean, it's amazing, because they probably heard the question before. They might not have heard the question before, but to you it's an important question that needs an answer. Investigate alternatives. Don't just assume there's only one approach, because there are multiple approaches that can be done. And when someone says this is the thing you should do, ask why, and ask someone else why, and ask someone else why. Because there are all sorts of implications, after effects of many of the procedures that have been talked about today. Some are not very positive. Some are horrible, by the way. So ask a lot of questions, push the things to get done, but as you're in active surveillance, be active. That's why it's called that. It's not passive surveillance. Be active. And that's my journey. I'll be glad to answer any questions or sing a song, whatever you like. We can tell a joke. Back to you.
I'll see you dance.
No, that and the MRI are about the same.
Very good. Well, thank you so much, Lee. That was very informative. Greatly appreciate the insight that you have. All right. Are there any questions? I did get one question, and I think I can probably address that after our last speaker. Would that be okay? Okay. All right. So our second speaker today is Mr. Tom Bilstein. Now, he, just like I am, is a California native. He was born in Long Beach, California, and about 20 years ago, he moved up to the East Bay with his beautiful wife, who is a lovely person and loves to collect lost cats, which unfortunately Mr. Bilstein is severely allergic to. So, he has now basically kept his allergist and practiced just all on his own. Tom began his career as a securities attorney, but we won't hold that against him today. And just very similar to Richard Gere's character in Pretty Woman, I know I can't get away from the movies today, he uses his legalese to acquire, operate, and sell small businesses for small profit, was what he told me. And with the wisdom and the expertise he has gained, he has started his second career in banks within the anti-money laundering unit in hopes of learning how to hide, sorry, Tom, giving away your secret here, how to save money from the IRS. With all that he's learned in his vast and varied career, Tom is now a financial consultant, and in his free time continues to grow his wealth by watching YouTube videos and learning about macroeconomic trends. I do have to tell you, I too am a big fan of YouTube videos. Unfortunately, Tom, you're learning how to grow your wealth. I'm learning how to fix my toilet. So I'm definitely watching the wrong videos here. But I digress. As fast as Tom is growing his wealth, he is also sneezing it all out by feeding his adopted feline children, mowing his lawn with a push mower, and visiting his allergist. Tom was diagnosed with intermediate-risk prostate cancer in 2021 and underwent something called high-intensity focused ultrasound, or HIFU therapy, which I believe Dr. Son had spoken about earlier. And just as a rewind, HIFU basically is a minimally invasive ablative treatment option that utilizes ultrasound to focus sound waves to target a specific location. In our case, this is the area of prostate cancer cells. The sound wave energy is transformed into heat that then burns or destroys the prostate cancer cells. So please give Tom a warm welcome.
Thank you, Sharon. Well done. Well, I'm really happy, actually, to be sharing my HIFU story with such a receptive audience, mostly because I found sharing my prostate cancer treatment at dinner parties, it doesn't go over well. So it's great to have a receptive audience for the first time. So I'm going to tell you my story of what was in my mind, what was happening to me. So it's a biased story about what's happening from my perspective, but I'll give it to you as it laid out for me. So my HIFU story kicked off in December of 2018 when my PSA came in at about a 4.4. And as this audience knows from listening today, it's good to have a PSA score less than 4, and the lower the better. So I was paying some attention, and 9 months later, in August of 29, my PSA was 4.2, and I started thinking, well, that's a downward trend. That's good news. But 16 months later, however, in December of 2020, my PSA was up to 5.3, and my GP at One Medical advised me to, hey, you got to make a date with a urologist because you might need a biopsy, based on this score. So go find out. So how did I choose a service provider? So in my opinion, the Bay Area's top two choices for hospital-level medical care are UCSF Medical Center and Stanford Health. It's kind of pretty much the top two. And my GP, her name is Nina Patel. She's a Stanford Medical School grad, and super clever woman, and she had previously referred me to Stanford Health in Emeryville, which is near my house, where I had a coronary calcium scan. And then when I was there, I figured out that their service there was so much like visiting a Four Seasons hotel that I didn't mind going there at all. So I asked her to refer me to Stanford at the Emeryville facility. So again, this was in now late 2020. So in January 21, right away, I had a Zoom call with urologist Dr. Rustin Masadi of Stanford Emeryville, that's when I learned that the best practice for prostate issues is to start with an MRI of the pelvis and prostate. I thought you just went in and he decided you have a biopsy or not, but studies have shown that MRIs are accurate diagnosing prostate cancer 93% of the time, compared with 48% for starting with a biopsy. So that was education for me. So I called and asked to be on the wait list. I wanted to let's get going and get this done if there's something to find out. So a month later, in February 2021, I had a prostate MRI at Stanford Emeryville. Then the next month, in March, I had a bone scan to see if there is any indication of cancer having spread in an area beyond the pelvis, because the MRI was pelvis-based. So when the MRI results posted on Stanford's My Health website, I started studying the findings. The MRI report is thick with acronyms, and so I spent a lot of time learning what they meant and trying to assess the findings. The radiologist had identified 2 spots within my gland that were likely cancerous, and no cancer was noted on the lymph glands or elsewhere within the pelvic area, and then the bone scan was negative. So basically I had it contained in the gland, and that was what I had to think about what was going to happen. So mentally, when you think about what are you going to think and feel when you find this news out, personally, I really didn't feel very shocked or particularly upset. It was almost more of a serious irritation that this is going to be a prolonged hassle. It's going to take time. It's going to take me away from what I want to do. I got to tell people about it. It's almost embarrassing in a way. And I think I had that reaction because I have friends and family who have been diagnosed with prostate cancer, and post-treatment, they're all fine. So I didn't have any immediate, panic in my mind. However, I'm pretty sure that if the evidence had come back that there was cancerous growth outside the gland, I'd be a lot more stressed and anxious because I perceived you were going to have a lot more work to do in order to handle the situation. So my bigger concern just mentally was on the PR front. So I felt an obligation really to manage the impact of the news on my friends and family. Because no matter your actual condition, you all know this, if you mention the word cancer, almost everyone defaults to, oh my God, the end is near. And basically they end up suffering needlessly because they're not dealing with the facts or the probabilities. So I decided to go and develop more insight before going public, something along the lines of being able to say, don't worry, I was in a wreck, I'm fine, but the car's going to need a little work. So something to get people past the panic attack that might come. So I just sat on the news and didn't go public. So as soon as I had characterized the MRI results, I started researching what's in the universe of prostate cancer treatment techniques and vetting them for how they might apply to my situation. And my assessment, of course, was that some kind of treatment's required, so I better make it happen quickly while the problem is still contained to the gland. So as you probably know, if you're in this space, the published treatments in the U.S., there's the active surveillance, surgery, radiation, cryotherapy, hormone therapy, chemotherapy, immunotherapy, targeted drug therapy. There's a long list of things that have been worked out over the years. There's a big menu. But I also found there were procedures available where they're not found on many of the official lists. For example, HIFU. HIFU is not listed even today on the American Cancer Association website as a treatment method for prostate cancer. However, I did find that HIFU's been an option in Europe since 2001, 20 years, and it's a mainstream treatment there. So after a few days of pondering my diagnosis, I started feeling pangs of anxiety bubbling up about my prognosis. So I called and I got a script for anxiety. So my belief is that anxiety is very hard on your immune system, and you really want your immune system optimized. So no matter the course of treatment that you're going to choose, you should just not tough it out and be a tough guy and live with untreated anxiety. Get on top of it. Because just like prostate cancer, anxiety or depression, it can grow into a huge problem if you don't treat it. So that's my personal bias and experience, but I would pass it on to anyone else who's in the same spot. So I needed a treatment plan, right? So in February 2021, I was trying to keep things moving fast. I conferred again with Dr. Massoudi at Stanford Emeryville about treatment options. And so I was pressing him, well, as you do, what do you think I should do? So he recommended radiation over several weeks. And I pondered his suggestion, but based on my review of the available prostate treatments and frankly what I was reading as their after effects, I formed a personal bias against wanting to have radiation, surgery, or chemotherapy. So I kind of got my mindset on, well, can't I do this other thing, HIFU? So I asked Dr. Massoudi if he could perform HIFU, and he said, well, I don't do HIFU, but you could chat with Dr. Son at Stanford in Palo Alto and see if I was a prospect under his protocols. So, so I felt a bit like a guy who's gone to a fancy restaurant and you're trying to order something that's not on the menu. It's like, what are you doing here? Like, I just told you radiation and you're trying to sell me on HIFU. But thankfully, HIFU has now come of age enough to where, we're speaking about it today and you're seeing it. And so it's making progress. But it's still not perceived as the mainstream treatment. I think because of the medical industrial complex, it takes a long time to get things through it. And it's in that process. So thankfully, I was able to confer with Dr. Son. He ordered a needle biopsy. So just 2 weeks after I was chatting with Dr. Massoudi and telling him I wanted to HIFU, I had a targeted prostate needle biopsy performed under ultrasound guidance. Now that's the exact same thing Dr. Son discussed today. So that was the procedure I had. And I was wide awake for the procedure, and you get to watch the action live on a monitor while you're laying there. It's riveting stuff, really. You should have been there. So during the needle biopsy, Dr. Son, he takes the MRI images that I had back in February that informed my initial diagnosis. And then he's also taking ultrasound images live at the time of my prostate, uses a wand. And then the software combines the two pictures so he can see exactly where he wants to target the taking of cores with the needle that he shoots in one at a time. So your job when you're there, my job, don't flinch when the needle's aimed and fired. And that's about it, all right? Be still. So on a 1 to 10, I would have put the pain at about a 4. And I was thinking about it later. I thought, dentists have probably caused me greater pain than a 4. And you get up and you walk out and you're a bit sore for a day, a little bleeding, but it's certainly not awful. So in order to get into the HIFU protocol, you need to have the right Gleason score to be eligible. And the needle biopsy is what gives you those Gleason scores. So each biopsy core is graded and given its own core. And one score for the arrangement of the cancer cells and a second score for the pattern of growth of the scores. And then they're added together. And the lower the score, the better, as we've heard today. And so my results out of 18 cores were 14 were benign, there was no problem with them, and 4 had issues. So I had 2 problematic locations. One of the cores was in one location, and 3 of the cores were in another general location. So I had 2 spots combining the 4 different cores. So the one location scored a 3 + 3, 6, so that's on the lower end. And the second location had what I call bad cores. One scored a 4 + 3, and 2 scored 3 + 4, both for 7s, with a 4-3 riskier than a 3-4. Only in medicine would 4 + 3 = 7 and 3 + 4 = 7 be different. But go figure, you get it once you learn it, but it just doesn't make sense. You should have called it an 8, right? So my HIFU prospects, we generally need Gleason scores of 7 or less, and so I qualified, so I signed up for HIFU. And at the time, Dr. Son was also conducting a HIFU research project, so I opted into his study, and I did a few more tests and things than you would otherwise have to do now, because the study is complete and they're looking at fewer things. So again, I was pushing to get my dates for things done. So on May 24th, 2021, Dr. Son performed my prostate HIFU ablation. I went down to the South Bay Surgery Center of Stanford in San Jose. And again, I had called and gotten myself on the waiting list so I could get the first available date. So to describe the procedure, from my experience, a HIFU procedure is very similar to having a colonoscopy. You get the same tasty drinks and the highly dignified preparation the night before as a colonoscopy. You get the same pre-op disciplines, right? You show up on the day, you pull on a gown, right? The nurse inserts a line in your arm. There's a meet and greet with the anesthesiologist, right? Your doc comes by, says hi. You get wheeled down the hall. You make a few sophomoric jokes with the people in the suite where the surgery is. You pass out. You wake up. You prove you can stand up without falling down. You go out to the car. They slide you in. Your wife drives you home, and you're done. It takes about half a day, maybe, to get it all to happen. Now, in advance, there's a game plan form for Dr. Son, of course, and during the procedure, he's using the imaging tools that guided your other biopsies things to target the tissue, so he can see exactly what he wants to zap. They're all predetermined areas that they're going to shoot, and they use the same visual technology to visualize it and zap it. So the HIFU probe, as they call it, generates sound waves, really fast sound waves, and they vibrate small sections, very precise, of pre-targeted tissue, and it vibrates so fast that it overheats the cells and they disintegrate. And so he zaps each targeted area plus a margin around each target so that you can have a little margin for error in case there's microscopic cells growing outside of the target itself. So it's very precise and very methodical. And the zapped material remains in place and your body just absorbs it over time, right? So you leave wearing a urinary catheter to make sure any swelling doesn't impede your ability to pee. And you pull it out yourself after 4 days, which is interesting, So you can bind a small catheter bag to your leg if you want to go places. You don't have to stay at home tied to the bed. You can go out the same night for dinner if you're in the mood. You take an antibiotic. Like all healing, to be fully healed, it takes about 6 weeks, but in less than a week, I didn't notice anything. And that's it, just done deal. You have a little blood in your urine the first couple of days, but no measurable pain. It's like you're not thinking, oh my God, this really hurts. It's just not there. Actually, my biggest fear it's kind of funny, but my biggest fear was I would lose my grip on the catheter tube when I'm draining the bag, and things would be flying all over the house. You have to repaint the bathroom. So, that's the biggest risk, I think, is don't lose your grip on the catheter tube when you're draining. So in the first year, and then you're done, you're out the door, right? And so the first year post-HIFU, you do your PSA every 3 months to track it. You talk to Lori every 3 months on Zoom. She checks in and see how you're doing. You have an MRI, and then you have an MRI again at 12 months, and a biopsy at 12 months. And then, so for me, my 1-year biopsy post-HIFU came back with 20 cores, and all 20 were benign. So there was nothing they could find. So obviously, for me, that was a good outcome. That's what everybody would want. My post-HIFU, my PSA scores rose sharply. They were 9.8 in August, just after the May procedure. They went up to 10 in September, and then they started decreasing. So they're 8 in December, 7 in January, 5 in May. At the 1-year mark, they were 471. In September, they were 395, and the one I just had the other day is at 427. I asked Dr. Son, well, what about that? It went up a little. He goes, don't worry about it. We'll see you in 6 months. So I don't think those were the usual or expected post-HIFU PSA scores. Lowers deemed better, but apparently the PSA scores can be quite high or low or all over the place post-HIFU. So talk about the time frame for this. For me, it was very important. I was trying to get everything done as fast as possible. So from being told on December 28th of 2020 to go see a urologist for a possible biopsy to completion of my HIFU on May 24th took just under 5 months. So from, hey, you better look at this, to being done with the HIFU, 5 months. And that was with me pushing for the first available date for each procedure. All right, so it's now 2 years and 4 months post-HIFU. I'm age 71. I feel very well. I don't take any prostate or urinary related meds. Didn't need them before, didn't need them after. And my romantic capabilities, they're no better and they're no worse than pre-diagnosis. So, you would have thought maybe I had a dental procedure. So that really didn't change. I pee about once a night if I've been drinking Chardonnay the night before, and less if not drinking. Bladder control works normally, no leaks and no urgency. And I had no infections during the entirety of my pre and post HIFU treatments. So from my perspective, I was very pleased. So I tried to recap what I thought were the benefits of HIFU because I see it as a low-risk option. So it's a non-invasive procedure, right? Nothing's getting cut. There's no chemicals, there's no radiation, there's no meds. You come out of it, you're done. There's no post-procedure rehabilitation. You're not having to. You've not been cut. You have no stitches. You're fine. You can walk around. You just have 4 days with a catheter and a bag. And frankly, you don't even have to get out of bed to pee for 4 days because you got this catheter. So I was thinking maybe I'd keep it, but then I thought, it's not going to work. So in my case, my bodily functions, so to speak, they worked pre-HIFU and they worked post-HIFU. So to me, I didn't measure any impact of the procedure. I had some small reduction in prostate size, and there's a small reduction in the prostate fluid production. You get 2 bites at the apple with HIFU, meaning I could have a second HIFU treatment given that I requalified at the time. So you can go back in and do it again, given that you don't have something that's not treatable with HIFU. I've retained the option to have all the other types of suitable treatment that Stanford might suggest and that we've seen up on here today. And now HIFU is covered by Medicare and medical insurance. When I had it just back 2 years and 4 months ago, it wasn't covered. You had to pay out of pocket. So now it's finally cleared and gets paid for by Medicare. So I have some personal tips to share with the disclaimer that these are my personal opinions and beliefs, not Stanford Health, not Dr. San's, not medical advice, just me personally. Consider it legal advice. So the medical staff here are great. They are, they're really, we all know that. And they have a ton of resources. But you still need to do your own research, right? You need, or if you don't know really how to do the research, you should sign up someone savvy in your family or friends to do the research for you, because there's a lot to look at and read and balance and make decisions. There's work involved in developing the information you need in order to decide upon any course of treatment. So keep pushing to complete your prostate cancer treatment education quickly. I mean, I don't think you should be wasting time. You should get on it and figure out what you want to do, whether it's active surveillance or something more. With cell division, standing still isn't in your best interest. You can call Stanford and get on the wait list for scans and procedures and shorten the time from diagnosis to treatment. So I believe that's smart to do so. And if there's a cancellation, they'll put you in. Ask a lot of questions about the various treatment options and their downside risks. You got to ask questions. You just can't go in there and be silent and be in shock, right? You got to start asking. Not every doc here performs every prostate-related procedure. Guys have specialties, right? They're studying things and they're very interested in their specific area. So you may need to speak with more than one doc. So don't be shy about asking to speak to one of the other docs who will have a perspective on that other procedure that maybe the one you've just talked to who's preoccupied with his specialty doesn't have. I think also it's in your best interest to become a bit of a health nut. Right? You don't want to conquer your prostate issues only to succumb to atherosclerosis or diabetes or some cognitive disease because you became preoccupied with your prostate issues. You got to start managing overall health because it helps also with curing prostate. You need to develop a routine to de-stress because this stuff can be stressful. So it's essential you talk to people. Just you find somebody you trust, you can kind of share the story with, get it off your chest. Do not ignore symptoms of anxiety or depression. See a doc and get a script. It's very easy, right? Work on sleeping well, long enough each night and with minimum interruption. And, I would suggest people study up on the best longevity and anti-aging practices, right? There's no shortage of information out there on what you should be doing to make your system work well, to optimize your health. And you want all these things working well because you want your immune system fighting this cancer with you. There's literature that strongly suggests eating sugar and carbs helps fuel cancer cell growth. So some people believe that a ketogenic type diet, one that's more protein, less sugars and carbs, can help manage cancer by burning ketones for your energy in lieu of burning glucose, which is what we usually do. And that then by starving cancer cells of glucose, it helps kill off cancer cells. So again, these are my opinions. I suggest it's worth your time to research the topic, though. It's called the Warburg effect, W-A-R-B-U-R-G. You can see it on YouTube. It's easy to explain. The guy, Otto Warburg, he won a Nobel Prize for discovering this mechanism of energy production in cells. So worth discovery, worth helping, things that can help yourself while you're taking your treatments. Exercise. It builds your immune system and it helps with your mitochondrial efficiency, which you need to have working optimally when we're in this condition. So I'd suggest you lift some weights and perhaps with a friend so that you keep showing up. Don't let your muscles deteriorate and let yourself just become sedentary. Just like the guy was showing use it or lose it, the same thing applies to your whole skeletal and muscular system. You got to get out there and pump some weights and get after it. And you have to engage in some cardiocentric activities, find something you like. And most of all, I think, we all know this, but don't let people men skip regular PSA testing when it's sensible for them to do so and they're just blowing it off. So, should you opt for HIFU with Dr. Son, you'll have the distinct pleasure of meeting with Lori over there, Lori Goulman, and she's Dr. Son's lead advanced practice provider. And she then, when you're done, she'll skillfully provide you all the advice you need post-HIFU. She'll relieve your angst. She'll make jokes with you, and she'll answer all your questions. So Lori Goulman is terrific, and she's right-hand woman to Dr. Son, so that's a real benefit to the whole system. So in closing, I'll say that I'm super grateful to Dr. Son that he mastered all of the various HIFU treatment techniques in his years of study, and feel very fortunate to have met him here at Stanford. He's really a great guy, as you saw today. And if you're a candidate for HIFU, I would highly encourage you to discuss treatment with Dr. Son. Apparently he has a lot of free time on his hands, and he's always happy to chat. So thank you very much for listening.
Thank you, Tom. That was very informative. I just want to open the floor for any questions for panelists.
Yes, so, sorry about that. So thank you both. This is a question directed to both of you, but Tom in particular, I noticed you mentioned discussing how you were concerned about the impacts of your diagnosis on the circle of people who are closest to you. I'd like to ask you to turn that lens around and ask, what are the things that they did or might have done, and of course this is equally a question to you, Lee, that helped you feel more comfortable, going forward. For those of us who want to support people who are experiencing prostate cancer and the treatment process, what advice do you have for us?
Well, I think the fact that when I shared with them what my condition was and what I had learned, that they would absorb it and get it, so that they kind of would quickly get into the same comfortable place that I was in, so that I could see that they weren't feeling anxious about things. So it was their ability to absorb and believe my true condition quickly, and before they had time to panic, if that answers the question.
And just to amplify that thought, the more the person who has cancer knows, the better they can explain the situation to the people they love and or live with. If you come back and say, I got cancer, and you stop the sentence right there, then people are going to draw all sorts of conclusions. But when you say, I got cancer and it's this kind and this is where and you just put together, shall we say, a package that the recipient can understand the parameters of. In my family, our two kids are both in high tech. They're both senior level people at this age. I mean, they're 50 years old. They ought to get there. But they're, so you can have an analytical discussion. So it's not one of these things where it's fear. It's more like, here's what it is. Here's what I'm going through. If you have questions, ask, because you might ask a question I can't answer yet, but I'll work on it. So it's really open communications I found more than anything else. It's when you drop the big C-bomb word on somebody and walk away that things go sideways.
Yeah, I can just ask this question.
No,
Sure.
but the people who are listening can't hear.
This might be for Lori as well, but are there any studies on the long-term effect? I mean, you had this done a couple of years ago now?
2 years and 4 months ago.
2 years and 4 months. Are there, because since it's been going on in Europe for years, are there any studies on the long-term effects and reoccurrence?
Yeah, that's a great question. For the live stream, are there any long-term studies on HIFU? And so HIFU has been in the UK. That's kind of, I think, the birthplace where it's been around for probably a couple decades at this point. So the data we have is based on the UK, and it's looking at over 600 men. And it is short term as far as prostate cancer goes, because we know prostate cancer is, slow growing, and it could be 10, 20 years to really get the good research. So the research we have is looking at men after 5 years of HIFU, and so it is limited. I think at this point, actually, probably in the next couple of years, we'll see more long-term data. But what it shows is that a couple things. It shows the risk of metastases is less than 2%. For the right candidates. And I think that's really important because we are now doing it, 3-4, 4-3. In some cases, it's even higher, so that's a different group. But for those qualified patients that really are within the criteria, the risks of incontinence are significantly lower. I think it's less than 1% of men require pads afterwards. 80 to 85% of men with good erections before will maintain their erections after. So significantly lower side effects, as Tom had mentioned. Once the catheter is removed, you're pretty much good to go for the most part. There is, because this is just treating that one area, there is a chance of 25% of men will need additional therapy in the future because the lesions could be in other areas of the prostate or possible recurrence, and you can then do focal therapy or any type of treatment afterwards.
What about 4-3s? Does that 5-year data cover 4-3s or not?
I don't know specifically. I think it's, I can't answer that.
And then a second question is, does Medicare that is not farmed out to anyone plus a supplemental, does that cover the entire cost?
You're asking some tough questions. So right now, I think that Medicare, I think Part A and B do cover it. I'm not sure about the limited Medicare. And I do know, as Tom had mentioned, a lot of more private insurances are starting to cover it whole. There are some that are still out of pocket, and it's about $16,000 for everything total. So Medicare, for the most part, yes, but if it's limited and supplemental, I can't speak to that. It's case by case.
First of all, I'd like to thank Lee and Tom for very informative information and other information. The question I have is actually twofold, and it has to do with patients that are, and I think you might have better perspective, this Sharon and others, that are more advanced. I think one of the things I was surprised with is when I came in, I was initially told that there's no cure for my type of cancer. And then when I had my PET, it wasn't as advanced, and then they said, oh, you're curable. So I wanted to see that perspective. And the second follow-up question is a perspective of a person going through all the treatments of ADT, brachy, and beam therapy, the cumulative effects, and what did they do to actually cope with that. And I'll give two examples. I did talk to, I'm in patient support group, and they're very helpful. And I mentioned, do I have to wear a diaper? And the first thing he said was, excuse me, it's an adult diaper. So I guess he wanted to make a big differentiation with that. And then he told me, some of the severe side effects. And the other thing I learned was ADT, after the first year, your side effects are even worse. And so all of these things I'm having thoughts about, and I think maybe your third person would have been able to answer that, but if you have a perspective of those who have more serious treatments as well as condition, metastasize, et cetera. Thank you.
So your question's right up my alley. So yes, As we get into higher risk prostate cancer, we tend to know that more treatment is more effective than less treatment. Most of the time, when you get into high risk prostate cancer, radiation tends to be a better treatment option. And the reason being is that, when everybody talks about prostate cancer risk, what are they talking about? Low risk, intermediate risk, high risk? What does that all mean? The easiest way that I can explain it is, what is your risk of the prostate cancer going outside of that local area, right? So if you're at low risk, it's a lower risk of getting outside. Intermediate risk, well, you maybe got a 50-50 chance of it going outside or staying exactly where it is. High risk usually means that you have a higher risk that you're going to have micrometastatic disease, right? And so we know radiation, focal therapy, surgery, well, it all works where it is. But what happens if you got 3 or 4 prostate cancer cells that have already sailed down and now are traveling throughout your body, right? You don't know where it is. We can't find it yet. And even the best diagnostic imaging test that we have, which is a PSMA imaging test, if it's such a small amount, we're not going to be able to find it. So what do? Well, we always add on something called systemic therapy. And I know that Dr. Parikh will be here to kind of talk more about the systemic therapy. But, the primary systemic therapy in treating prostate cancer is androgen deprivation therapy, okay? And for those of you who don't know what it is it's not women hormones that we inject in. Everybody goes, oh my God, am I going to come in and see you next time in high heels and lipstick? No, I haven't seen that yet. But these androgen deprivation therapy medications generally turn off your body's ability to make testosterone. And the prostate cancer cells utilizes the testosterone to grow and feel and progress. So if we turn those off, our hopes is that, well, maybe we can starve them out, and so the little bits and pieces that have escaped out there, we're able to squash them, okay? There's also clinical research study that shows that when we do ADT, it makes the radiation work better. Why? I don't think anybody's figured that out yet, but it does. So when we take a look at that, right, obviously at this point we want to throw everything that we have at it. The more we can throw at it, the higher incidence that you can get a cure, right? And so we do generally recommend a course of high-dose rate brachytherapy followed by external beam, and then anywhere from 18 months to 24 months of androgen deprivation therapy. Now, if you've got nodal disease, so we do a PSMA PET CT scan and we see that there's a node that's lighting up, we refer you to medical oncology, the smarter people, and they will go ahead and talk to you about oral intensification with things called abiraterone and prednisone or enzalutamide, right? Generally, if we see something that's still, there's a lot of nuances, right? I mean, here's the thing. How many of you have been diagnosed with prostate cancer and are like, what? I feel perfectly fine. I didn't even know I was sick, right? That's a wide, big majority of patients, right? And so now we're telling you, you've got prostate cancer. We want to treat it, right? And our hopes is, number one, we want to make sure we treat and cure your prostate cancer. But the second thing that we really want to do is we want you to come back from your cancer treatment the same way you came in, not even knowing that you were sick, right? And so that's how we try to piece together and figure out what is your best treatment option. And every person is different, right? Everybody's prostate gland is different, and everybody's lifestyle is different. So lots of times I'll have patients come in, they're like, oh my God, Sharon Chin, what should I do? And I'm like, I don't know, because I don't live your life, right? So I really do recommend and really advise patients to talk to urologists, talk to 2 urologists, talk to a radiation oncologist, talk to a second radiation oncologist. Make sure you talk to medical oncologists. Find out every information that you can find, and then look at your lifestyle, right? What is important to you? There are a whole slew of side effects that are with each different type of treatment. What are you going to be willing to live with a year from now, 3 years from now, 5 years from now? Did I answer your question?
Thank you very much. We're going to take one more question, and then you guys have definitely been very patient. We'll go to lunch after, and I'll just do a brief blurb about the breakout session.
Okay. So I also have a question here that says surgery versus radiation. How best to decide? So I don't know if you guys know or don't know, but it was a surprise to me. So radiation and prostate cancer was not my initial area of expertise. And so when I came and I worked with radiation oncology, I was like, oh God, right? What do I need to learn? And the first thing my attending says, don't worry, I'm gonna teach you everything you need to know, okay? And over time, he has, and a lot of patients have also taught me a lot of stuff. And what I have learned, there are two camps in prostate cancer treatment and diagnosis. There's a camp where it's slow growing, you're probably gonna die of something else, right? Then there's a second group, right, that says, oh, well, you've been diagnosed with prostate cancer, and although it might be a small problem, it can turn into a big problem, and, maybe we should treat it early. Okay, there's no right and there's no wrong, right? You kind of have to decide where it is that you sit, right? I tell my patients, I'm the one that is, there's a problem, I just want to nip it in the bud now. But my dad, he's like, I'm doing great, no problem, I'll wait until it gets to be a problem, right? So there's two ways of looking at that. What I can tell you is, I think that the earlier you treat your prostate cancer, the better your chances of you being able to cure it, okay? So how best to decide between the surgery and radiation? You really have to talk to the surgeons. You really have to talk to the radiation oncologist. Find out what those side effects are. Nail it down, right? And then you need to figure out what is most important to you, right? There could be urinary changes. There could be bowel changes. There could be erectile function changes. And those are kind of things that you need to keep in mind and deem what is important to you, right? So like I can have a gentleman that was 80 years old. He had a really big prostate gland. And, every 2 to 3 months, he had to go into the emergency room and get a urinary catheter put in, right? Because he couldn't urinate, right? So I can tell you, if we radiate it, he might end up being dependent on that catheter, right? So we talked about it, well, maybe you'd be better having it removed, right? So then he went to the urologist and talked about it, and the urologist goes, well, you're kind of advanced age. Maybe radiation would be a better option, right? So then he learned about it's big, it's large, there are also risks associated with that, right? So obviously he's got risks of doing radiation, he's got risk of doing surgery, and in the end, it was up to him to decide what side effects was he comfortable with. Does that answer your question?
Thank you.
You're welcome.
Thank you very much. I want to give a big round of applause to Sharon, our moderator, and especially to Lee and to Tom. Lee and Tom, thank you so much for sharing your prostate cancer journey with us. It was incredible. Thank you.